Ladies, gentlemen, Assalamualaikum warahmatullahi wabarakatuh, and good morning to you all. My name is Azrul Maude E, the head of the Galen Center for Health and Social Policy. Welcome to this morning's webinar titled Malaysia, How Ready Are We in Advancing Personalised Healthcare? Thank you for graciously spending your Saturday morning by being here to listen and participate in the upcoming discussion. The agenda for this morning's program can be downloaded via the link shared with you on the chat box. At the Galen Center, as an independent public policy research, advocacy, and communications organization, we are always on the lookout for opportunities and partnerships from government and the private sector to initiate and support conversations which help the ongoing reform and transformation of Malaysia's healthcare system. We are fortunate to have for this morning the Jeffrey Chia School of Medicine and Health Sciences of Monash University as co-organizers for this morning's webinar, as well as the ever-present support of Roche Malaysia. Ladies and gentlemen, we have an interesting panel of speakers lined up to share their thoughts and discuss the topic of personalized healthcare. We will shortly hear the findings from the Asia Pacific Personalised Health Index findings and the implications for Malaysia. With this webinar, we are hoping for continued discussions around what kind of opportunities exist in this area to further future-proof our healthcare system by strengthening evidence-based policymaking and to call for further government and private sector partnerships, resources, and commitments to digital and personalized healthcare. This is a disruptive time, and perhaps that's a little bit of an understatement. It may seem a bit strange to talk about personalized healthcare at a time when COVID-19 dominates most conversations at meetings, conferences, and even dinner tables. But history informs us that turbulent times like these are usually the best times to discuss and introduce changes and reforms to move away from business as usual or the normal way of doing things which are comfortable and may lull us into complacency. The lessons learned from the ongoing COVID-19 response is making a strong case for the need to commit and invest to personalized healthcare. Real-world data is being used to evaluate and understand the effectiveness of existing vaccines and therapies. Insights are coming from the bedsides of patients, informing those in laboratories doing research, helping to steer future treatments. The science of medicine has allowed us to make incredible advances in diagnosing and treating diseases. We'll hear about some of that work which is being done here in Malaysia by our own researchers and clinicians. How we apply these lessons to the diagnostics and treatments of other diseases such as cancer by ensuring each person gets the right treatment at the right time will not only allow people to live longer and better lives, it will save them too. Ladies and gentlemen, digital health has put unprecedented amounts of data now in the hands of clinicians, informing and guiding discussions and providing opportunities to make the best decision regarding therapy for the patient. But personalized healthcare is not only about treating and preventing disease for individual patients, it is also about rethinking the healthcare system for future generations. Personalized medicine can deliver efficiencies that will keep healthcare systems sustainable in the face of ever-increasing rising costs of healthcare. For all these reasons, the Galen Center has convened this webinar together in partnership with the Jeffrey Chia School of Medicine and Health Sciences to discuss personalized healthcare in Malaysia. How ready are we? And how we can build on existing work and partnerships to move forward. I thank you again for attending, and my appreciation to all our speakers today for their availability on this sunny Saturday to talk to us about this topic. I now would like to invite Dr. Yasha Nikolai Rybak, who is the Medical Director at Roche Malaysia, as well as the Director of Integrated Patient Journey Partnering, to say a few words of welcome. I do believe that he himself has been a researcher into the area of antibody-based tumor targeting, making this topic very relevant to him. Dr. Yasha, the floor is yours.
Thank you so much, Asrul. Yes, it's a long time back in my career that I was doing research, but I'm of course very passionate about this topic. And on behalf of Roche Malaysia, it is my absolute honor to welcome you all to this webinar. Thank you for joining us today. Each one of us is different, from genetics, from our lifestyle, from the environment that we grow up and live in. And so is each patient different, has different risk to get a disease, can have different variations of the same disease, and may respond completely differently to the same treatment. Understanding these differences is critical for providing optimal healthcare to each individual. Personalized healthcare means a shift from treating a disease with a one-size-fits-all approach to delivering patient-centered healthcare by applying the right health intervention to the right person at the right time. And that in a holistic and integrated approach from prevention to diagnosis, to treatment, and to monitoring. PHC brings together medical science, digital technology, and data science that enables treatments to be tailored to the individual. And PHC creates unprecedented opportunities for patients, physicians, researchers, and health systems. PHC brings together these advances in many ways. Systematic collection of analysis of data, systematic collection and analysis of data from clinical studies and patients in the real world will enable us to provide better care options, speed up the discovery of new medicines, and inform policies that enable access. Advances in diagnostics and including genomics will allow us to predict who is likely to become ill, diagnose illness earlier, and understand the unique characteristics of each patient's condition and response to treatment. And digital technologies will allow healthcare providers and patients to better track, understand, and manage day-to-day and long-term health, and enable more timely detection and individualized care. The COVID-19 pandemic, as Asrul also alluded to, has been a catalyst really for accelerating acceptance and adoption of telemedicine and other digital tools. Making the commitment to combine these transformative advances in these areas, together with the deeper understanding of health behaviors, will enable health systems to improve care and to distribute better the resources. It will enable researchers and manufacturers to conduct more targeted and efficient research and development. It will enable healthcare providers to offer more personalized, integrated care. And ultimately, it will enable patients to become more empowered to manage their own health. For more than 20 years, Roche has helped lay the scientific groundwork for personalized healthcare with targeted therapies, precision medicine, and diagnostics that help doctors to determine the right treatment for their patients. And now, as Roche Group, including Roche Diagnostics, Roche Pharma, and Foundation Medicine, we are evolving and extending this personalized approach across all elements of patient care. With profound advances in data, analytics, and digital technology, we are transforming how medicines are discovered, developed, and delivered to patients. At the same time, we strongly believe that collective effort across all relevant stakeholders is essential, and a multitude of collaborations are already underway. The COVID-19 crisis has demonstrated how stakeholders can forge new paths and partnerships to find and deliver solutions for a greater common cause: the health of people across the world, the health of all of us. We are all in this together. This approach, spurred by the pandemic, and must be really adopted to tackle other major systemic health issues. And this is why, As Roche Malaysia, we are so glad to support this event today here to discuss more on how ready are we in advancing personalized healthcare in Malaysia. Today, we are most fortunate to have a panel of distinguished experts who will share and discuss the outcomes of the Malaysian Personalised Health Index. Malaysia already has digital infrastructure and digital collection capabilities, but there is potential to do more. I look forward to the input and discussion from our expert panel members today on key actions that are needed to move this forward. I would like to thank our distinguished experts for taking the time today to discuss this important topic. Thank you very much, Professor Dr. Maude, Professor Datuk Dr. Rahman, Dr. Muhammad Asrif, Dr. Chia, and Professor Datin Paduka, Dr. Theo. And thank you to all the participants, to all of you for being here to learn more about personalized healthcare. Thank you very much.
Thank you, Dr. Yasha. Our program this morning begins with a presentation by Professor Dr. Maude E. Phipps, who will be speaking to us about the findings from the Asia-Pacific Personalised Health Index. Let me give you a little bit of an introduction for her first. Prof. Maude is a professor of human genetics at the Jeffrey Chia School of Medicine and Health Sciences, Monash University Malaysia. She undertakes research in human population genetics and health and established the first molecular immunogenetics and transplantation matching laboratory service at the University of Malaya Medical Center. She helped pioneer biomedical science program there and expand research programs in molecular genetics of autoimmune diseases. For some of the participants here this morning attending this webinar, she might have even been your lecturer when you were doing your undergraduate or graduate studies. Prof. Maude, the floor is yours.
Thank you very much, Azrul. It's a pleasure to be here. Hello, everyone. I'd just like to record my thanks for the support of Professor Shah Yassin, our head of the Jeffrey Chia School of Medicine, and also Professor Khalid Kadir and my colleague, Dr. Badaria, who is with us today. So it's a great pleasure to be able to engage so many members and stakeholders in the healthcare industry and also academia and other industries in Malaysia. So what I would like to do today is, before I jump into actually highlight some of the findings of the Asia-Pacific Personalised Healthcare Index, I would just like to set the scene, as it were, to give you an overview of what personalized healthcare means, drawing from some of the early initiatives and the foundations of precision medicine. Next, please. Right, so change is the only constant, and it is now, we are right in the middle of the COVID pandemic, and many things have spurred change, even more so in recent years, right? We have COVID-19, we have challenges, we know that people are living longer, and we are witnessing now a fundamental change or a shift in healthcare practice, delivery, funding, and also experiences. And it is more so than now that healthcare needs are swiftly changing. So we have to look at opportunities for prevention, treatment, management, and so on, in order to be able to make the best of our health and whatever we can deliver to the citizens globally as well as locally in terms of healthcare. Now, my brief talk will look at a few areas. One is the introduction. What is personalized health? Followed by the Personalized Health Index Asia Pacific. We look at the vital signs and the parameters that were considered in generating this. And finally, where is Malaysia and how we can improve to kickstart the panel discussion. Next. So personalized health, some of you may well be aware, is linked to precision medicine. And several years ago, the NIH gave us an understanding, or rather a framework for precision medicine. And it is based on the 4 Ps: predictive, preventive, personalized, and also participatory. Next, please. When it comes to predictive medicine, this often alludes to identification of high-risk individuals that may have specific causative mutations, which can be detected these days and several years ago already, before the onset of disease manifestation, for intervention and to a certain extent to try and reduce the severity of the disease. Predictive medicine is sometimes, seen in the realm of genomic medicine, and it is available usually through national healthcare services in many developed countries, perhaps some private laboratories, hospitals and labs in the developing world, and also of late by direct-to-consumer testing. So some of you might have heard about 23andMe and so on, and there are many players in this scenario. The examples here I would like to talk to, which the panelists will actually expand on, would be also predictive in terms of testing for familial cancer. And you might be familiar with BRCA1, where mutated forms can account for 55 to 65% of risk of developing breast cancer. We have also BRCA2, for example, and you can see some statistics here, in contrast to people who have the normal gene for BRCA, where the risk is only about 12%. The next disease is familial hypercholesterolemia, which we see in Malaysia. It is a cardiovascular problem. And with this particular mutation that can run in families, the genetic mutations have been identified and can be used to actually guide ways of managing health and alerting the health provider to patients' needs and development of perhaps myocardial infarct early in life, in their 20s. Next, please. This is just an example also of a severe adverse drug reaction. You can have a look here. And this is a severe drug reaction to carbamazepine, which is a drug used to treat epilepsy and bipolar disorder. And you can actually look at the lesions here on this particular patient. And it is important because Asians as a community may well have the HLA gene B*1502 that makes them more susceptible to developing this horrible side effect from this drug. So one would like to actually genotype before this drug is actually prescribed to patients. Next, please. The next aspect of precision medicine is preventive medicine. And this is, of course, mainly targeted at diseases and conditions which form the majority of cases that we see worldwide, which are highly influenced by environment and lifestyle. And this, in genetic terms, we denote it as having lower heritability, where this does not really run in families. And the poster child, if you like, in Malaysia and many parts of the world is diabetes, where we already know that we can actually prevent diabetes by taking care of our diets, by exercising more, by reducing excessive weight, and so on and so forth. So this is an aspect of predictive medicine. Next, please. The third P talks to participatory. And even now, we are already part of participatory medicine in the sense that we actually wear quite a lot of technologies that are constantly monitoring maybe our heart rates, how much we walk a day, how many steps we do, and so on and so forth. So there is a whole avenue where participants and various stakeholders in healthcare systems can each do their part to promote better individual and community health. Now, apart from wearable technologies and the industries that have mushroomed around wearable technologies, we have these very large national projects that are participatory in nature. For example, the Chinese Precision Medicine Initiative. This was started in 2016 to a tune of US $9 billion funding, and it is a private-public partnership. Some of you may have heard of the Genomics England project, started in 2012, about 23 million in terms of US dollars for funding. You have heard maybe of UK Biobank and so on. And there are quite a number of projects in the States, in Europe, in Australia, and also in Saudi Arabia. This just gives us an indication about how governments and how industry and nations are very serious about this particular aspect of medicine. Next, please. The fourth aspect of precision medicine would be personalized. And this slide is a little bit busy, I do apologize, but I would just like to illustrate here how patients with similar endophenotype categories may have biologically distinct disease profiles. And you can see here the endophenotype categories, which can be actually teased out using deep phenotyping, a lot of data analysis and data integration, and making use of all sorts of technologies, from DNA technologies to RNA technologies, to protein profiling, metabolomes, microbiomes, clinical exposures, and so on, in order to cluster different people into different clusters for targeting precision medicine interventions or outcomes. So here we see the outcomes, for example, ranging from optimal changes towards health, to biomarker detection, to precision medicine selection, rational polypharmacy, and even to tailor environmental exposures insofar as it is possible. Next, please. Next, please. So that, in a nutshell, is sort of where personalized medicine sits. Now, what is personalized healthcare? And it is so obvious to us in this pandemic of COVID that, you know, many people are walking around. Some may be infected and ill, or even asymptomatic. Some people may be naturally immune. Some people remain healthy. So we do have all these variations in terms of populations. This little illustration shows a patient group in terms of pharmacogenetics, where in the old days, we used to think that if there is the same diagnosis or similar diagnosis, the same prescription could be actually used for all sorts of people. But we now know that genetics plays a big role in whether or not the drug that is prescribed is toxic but beneficial to the patient, whether or not the drug is not toxic and not beneficial to some patients, where the drug is toxic but not beneficial. And in the best outcome, we would want to target people where drugs are not toxic and yet beneficial. So a particular drug should only be used, for example, in these white individuals here, and really of no use to the others that are shown. So we move on from a one-size-fits-all treatment of disease to personalized healthcare, where it involves maintaining high and healthy quality of life over a lifespan, applying the right health interventions for the right person at the right time. Next, please. So what constitutes a personalized healthcare system? And we could think of it in terms of this. It would require the collection and analysis of meaningful health data at scale, because one or two do not make a system. One has to look at things in terms of populations, communities, followed by the integrated use of tools and services to tailor prevention, diagnosis, treatment, and follow-up to each person, which results in the cultivation of individual and population health. Next, please. So, what is the Personalised Health Index Asia Pacific? It is a unique data-driven policy tool to measure readiness of 11 health systems across the Asia Pacific region, including our country Malaysia, to adopt personalized healthcare. And it was actually designed and it came about from collaborations with 15 health experts from 11 countries that you can see here: Australia, China, India, Indonesia, Japan, Malaysia, New Zealand, Singapore, South Korea, Taiwan, and Thailand, working very closely with a core team of future-proofing healthcare researchers to identify and validate data sources. We also liaised closely with official representatives from health ministries, and I'm happy to say the Malaysian Health Ministry was very forthcoming and cooperative in providing quite a lot of the essential data that was used on national plans, on national policies, and data related to personalized healthcare. You can actually look at this website to know what this health index is all about, and there are further information and details. Next, please. Next, please. Yes, so here are the objectives of the Personalized Health Index. Mainly to know where we stand in this initiative, to highlight successes where each country has something about which it can be proud. Secondly, to identify focus areas and drive policy change, where each country, of course, has also areas that could actually be targeted for improvements to actually move forward better. Thirdly, to encourage best practices by applying expert knowledge and using a foundation of reliable data. And finally, to inspire collaboration, where we encourage participation, challenges, and contributions from anyone with an interest in future-proofing healthcare systems. Next, please. So the PHE design is based on 4 vital signs shown here. One is policy context, followed by health information, and then personalized technologies and health services. Next. So the definition of policy context would be the policies, frameworks, partnerships, people and drivers that facilitate personalized healthcare. For health information, we looked at the data, the infrastructure, and technical expertise that will drive this initiative. In terms of technologies, we considered the devices, applications, platforms, perhaps reimbursement structures, driving this based on stakeholder needs. And in terms of health services, one looked at the planning, organization, and delivery of services that drive personalized healthcare. Next, please. And these were the measures that were actually incorporated into the data, ranging from personalized health strategies, to scale up funding, to whether or not there were genetic counselors in a particular country's healthcare sector, to the use of electronic health records in terms of health information, to AI in healthcare, to wearable technologies, and to R&D expenditure, whether or not there was drug approval and reimbursement. Did it take time for regulatory approval? Are there registries? What is the quality of the registry? Is there access? And evidence-based guidelines. So these were the measures that were taken. Overall, if we look at the 11 countries, Malaysia is in 8th place. So if we look
warning,
at
Dr.
chart,
Prof Maude.
Yeah, thank you. 1 minute left. Okay, so here we have these focus areas. Next, please. So once you get into the index, you will see this. Malaysia is in the 8th position in terms of, we have good financial support for scale-ups. We are 7th for personalized health strategies, and also 7th for data infrastructure. Next, please. So these are areas of focus for improvement and also discussion, perhaps: personalized health strategy, data, digital infrastructure, and we can look just next door to Thailand for some of the best practices that they have actually put in place. Next, please. Strengths. We have quite a number of strengths, mainly in terms of scale-up funding and also in terms of evidence-based guidelines for care. And we should avail ourselves of various opportunities such as talent development, joint private-public partnerships, and so on, as seen here. Next, please. So I will end my overview here. I thank you. And yeah, let's open the room for chat and discussion. Thank you.
Thank you, Prof. Maude. Thank you for that illuminating discussion. I must confess that I have quite a number of questions to ask, and definitely I've got to hold on to that until we get to the introductions for the panelists and properly go into the panel discussion segment. So speaking of which, I must introduce our panelists properly, as they are as distinguished and luminous as they come. So let me get through the introductions for our panelists first, and then we can go straight into it. We have Professor Dr. A. Rahman Amal, who is the chairperson of the Precision Medicine Initiative at the Academy of Sciences Malaysia. Prof. Rahman is a senior consultant and professor of pediatric hematology and oncology and molecular biology. He is a researcher who pioneered personalized and precision medicine and is the founding director and principal research fellow of the UKM Medical Molecular Biology Institute, or UMBI, focusing on genomics medicine. He currently drives new challenges in cancer research, including the Cancer Genome Atlas Malaysia. Dr. Muhammad Ashraf Ahmad Anwar is a consultant clinical oncologist and the president of the Malaysian Oncological Society. He completed his specialist oncology training at the Christie Hospital and Radiation Oncology Fellowship in Canada before returning to Malaysia in 2007. He served as the National University of Malaysia's Medical Center as a consultant clinical oncologist. He has served on various national oncology committees, published in peer-reviewed journals, participated in clinical trials, cancer advisory boards, and expert panels. Dr. Chia Wee Hoi is a consultant geriatrician and the head of the medical department and clinical research center over there in Hospital Taiping. He is a graduate of University of Malaya and holds an MRCP from the UK Royal College of Physicians. He pursued a geriatric medicine fellowship at the Kuala Lumpur Hospital, University of Malaya, and Tan Tock Seng Hospital in Singapore. He has extensively researched and published numerous papers in his area of geriatric medicine. Dr. Chia has a special interest in digital health and personalized healthcare. And finally, we have Professor Datin Paduka Dr. Teo Su Huang, who is the Chief Scientific Officer at Cancer Research Malaysia. Prof. Dr. Teo won the prestigious Royal Society Dorothy Hodgkin Research Fellowship for her work on understanding DNA repair in the UK and returned to Malaysia in 2001 to establish Cancer Research Malaysia. She is the principal investigator of the Malaysian Breast Cancer Genetic Study, the Malaysian Ovarian Cancer Genetic Study, and the Malaysian Mammographic Density Study. Professor Dr. Teo is an adjunct professor at University of Malaya, was an Eisenhower Fellow, won the Top Research Scientist of Malaysia Award in 2014, and is a fellow of the Academy of Sciences. Well, ladies and gentlemen, there you have it. It's quite a top-notch, heavy group of people that we have this morning who are with us to discuss the issue at hand, and I do hope that you'll be able to take advantage of their presence here and to be able to ask questions to the panelists as well as to be able to get their answers. If I would like to ask that those who are participating, attending here today, please do enter your questions into the Q&A panel, which is at the bottom of the screen. And we will endeavor to get them answered online or offline, depending on whether we are able to do so at that particular point in time, but please do enter your questions to the panelists through the Q&A panel. So let me just kickstart the discussion this morning, and we have Prof Maude joining us with us as well. Let me ask the first question to you, really, Prof Maude, responding to your presentation just now. What do the Asia Pacific Personalised Health Index findings really mean for Malaysia, and how can the index actually open up opportunities to expand on personalised healthcare? I mean, I refer back to your slides that you presented earlier, and we need to be able to look at the nitty-gritty, but also the pragmatic implications of what you presented in terms of the findings. Please go ahead, Prof Maude.
Thanks for the question, Azrul, and it is timely that we have such discussions. For me, just to share some personal insights, it was a opportunity when I actually got invited to be an expert on the panel of the index to join the Futureproofing Healthcare initiative, because I felt that it was really time for us to take stock in Malaysia and in ASEAN and other countries on the potential of this area moving us forward into the future. Now, if we look at the link, and Stephanie has actually posted the link to the index into our chat box. I encourage people to go into the link and have a look at it. I just like to reiterate that 11 countries were involved in this particular index, and it is by no means an index that is a competition, okay? So the first thing I want to say is, let us not view this as a competition. Let us view this as a wake-up call to be able to start building an ecosystem in terms of education, in terms of healthcare provision, in terms of spreading awareness, that this is something that is really, really powerful and very now. So 8 in a total of 11 countries is a good place to be. It gives us an indication of what our strengths are based on the 4 vital signs that were measured, and it gives us indications of where we can improve. So for me, this health index is an index that presents opportunities for betterment and also for developing a personalized health, precision medicine in a better and more coordinated way in this country as we go together with our partners in healthcare and industry and academia in the region. Now, the index opens several opportunities. The first opportunity I see it opening is an opportunity for health and health education, an opportunity for infusing some of these elements into how we train medical students, how we train healthcare personnel, how we train biomedical scientists, and you can look at the relevance of the omics, if you like, in terms of the biomarker discovery and things like that. So it gives us an opportunity for training people to be sort of aware of what is happening in the context of how they fit into the big picture. The second opportunity I think it gives us is gives us an opportunity to critically look at the Malaysian scenario in terms of what has already happened in the past and where we would like to go from here. It gives us a way to take stock of and ask the questions whether or not the initiatives in precision medicine and so on in the past, the initiatives of establishing electronic health records, for example, many years ago in Hospital Selayang, that was the first hospital in Malaysia to actually have EHRs. What's happened since then? We need to be able to map progress, and we need to be able to have targets that are actually viable as well. So, and the third opportunity, I think, is it opens up avenues into where the private sector is in this initiative, where they're already doing very well, and we can see in the index that there is a lot of support for digital devices, in terms of wearable technologies, in terms of partnerships to actually have digital health programs and so on. And of course, the opportunity to educate the general public to come on board this, because this is something that is happening, and I don't think we can afford to lose out.
Okay. Thank you, Prof. Maude. That's quite a comprehensive way of looking at where this index can actually open up opportunities for Malaysia. And certainly I want to get a response here. And perhaps I will go to Professor Dr. Rahman Jamal. And this is, how does this mean, when we're moving away from a broad generalized approach to healthcare to one that is bespoke or personalized to the individual, improve on health outcomes? What does this mean for the individual? And I ask you because you're heading an initiative that's looking at precision medicine. So what do you intend to see happen as a result of your work in this area? Prof. Jamal.
Yes, thank you for inviting me to be a panel member this morning. Pleasure to be with such a distinguished panelists. Well, I believe this would promise more effective sort of healthcare approaches for the individual and the population. If this is implemented correctly and, widely, from diagnostics to treatment, as well as preventive approaches. But I believe there's a lot of things that needs to be done. Personally, I believe it should start with a clear policy on where the relevant ministry, of course, the Ministry of Health would be the major stakeholder here, in terms of how serious we are in adopting personalized healthcare or precision medicine. Because I think at the end of the day, as the speaker, as Prof Maude has presented, there needs to be a paradigm shift. We cannot sort of continue what we're doing now. There are a lot of wastage because many drugs are not effective in certain diseases 100% of the time. And we need to really start looking at the individual with respect to what has been mentioned just now, genes, lifestyle, and individual and environment, and maximizing the effectiveness of care. I think that's my response as well. Yeah.
Thank you, Prof. Rahman. I think what you just mentioned there, the effectiveness of care, is very important in terms of what we want to get from personalized healthcare. We want improved health outcomes. And I have to forward this question to Dr. Dr. Azrif, really, when it comes to it, you're an oncologist, you see cancer patients. So, what are the examples of how personalized healthcare and oncology have resulted in the kind of better understanding of disease as well as likelihood of being able to come up with and save lives from your perspective as a person who sees cancer patients and perhaps even utilizing some of this in your daily work?
Okay, thank you very much, Azrul, for inviting me to be part of this panel. And thank you for the question as well. In oncology, we've been practicing personalized healthcare for a while. And I think at basis is really staging of the cancer. So for example, we would initially then stage a cancer to decide which treatment is most appropriate for that particular patient based on his or her stage. But moving forward, the problem that I foresee here is basically is an issue of funding. A lot of the new precision medicine techniques, for example, genetic profiling in breast cancer costs money, and insurance companies are not willing to cover this, and it's a bit too expensive for the Ministry of Health as well. Although the treatments and techniques, tests as it were, are available, but it's an issue of accessing this personalized medicine really. So funding is an issue. Secondly, as well, is educating the medical practitioners and the nurses as to the significance of the results when we get when we get the test results. This is another thing that we need to focus on. And thirdly is in terms of prevention of cancer. So if you identify a high-risk individual, someone, for example, BRCA1, BRCA2 mutation, who we need to monitor and screen these patients for cancers, we don't really have a nationwide system in place to monitor these patients properly. Definitely, we don't have it in private hospitals. Government hospital, as far as I'm aware, only UM has it at the moment. So it is still quite limited, I feel.
Thank you, Dr. Ashraf. I did want to pick up your point just now and basically using personalized healthcare to address the issue of possibly late staging. I mean, the fact that a lot of cancer patients are presenting late, and which is something that a real issue for Malaysia, seeing how 70% of cancer patients are appearing at stage 3 and 4, you know, after the initial diagnosis, and they're coming with fewer options for treatment and then a lower chance of survivorship. So how can personalized healthcare work to the benefit of these people, in your opinion, Dr. Ashraf?
Well, to pick up these cancers at an early stage, basically you need proper education, public education. But I feel that public education itself is not enough. It's also access to care. In the Klang Valley, we are quite fortunate. We have many hospitals nearby, but there are still pockets. For example, the urban poor who have difficulty accessing, possibly because of work commitments, childcare commitments, elderly care commitments as well. Also, there is we see it now with the proliferation of anti-COVID-19 vaccine information over social media, the fear mongering that's going on. So a lot of a promotion of alternative healthcare products, supplements, vitamins that they claim can cure patients if they have cancer. So I feel it's a huge mountain. Well, it's not. People say that it's one mountain to climb. I don't think it's a mountain to climb. I think it's like a whole range of mountains that we need to climb here. So in terms of addressing presentation, the late stage presentation, I don't think it's just one issue. Personalized healthcare can help, yes. We know that we can screen for nasopharyngeal cancer by the mass screening of plasma EBV DNA, right? And that can pick up. There's also low dose CT scan for lung cancer. There's mammogram screening for breast cancer, but as yet we don't have a nationwide screening program for something like colorectal cancer. It's still a very ad hoc situation. So I feel that we need to get the basics or the foundation right first before we can move on to fine-tuning things with personalized healthcare.
Okay, well, thank you, Dr. Ashraf, for pointing out some of those gaps, but they also represent opportunities, right, for us to be able to work on, and especially for a lot of stakeholders are wanting to play a role in terms of personalized healthcare. These gaps actually represent opportunities for us to be able to invest, to put resources to, and also address. And thank you very much for highlighting that within the context of your work. I want to pick up some of the points that Dr. Ashraf and Prof Maude mentioned earlier, and Prof Rahman spoke about, and bring this to Dr. Chia. And this is on the issue of, Malaysia's components of healthcare. You know, we've often been described as being siloed and unable to work and innovate. And, when we look at the public health sector, we feel that sometimes they are at risk of being left behind compared to the private sector. I want to ask you whether this is true, and how can we encourage more information sharing collaboration? Because you work as the head of the Clinical Research Center over there in Hospital Taiping. So obviously you've seen a lot of collaboration. Obviously you've seen a lot of examples of success. What can you share with us in this area of personalized healthcare that we can actually improve upon? Go ahead, Dr. Chia.
Thank you. So I think what Prof Maude has mentioned earlier, in terms of Ministry of Health, I think they are quite forthcoming when certain collaboration works are done, and I think from the index, a lot of information are obtained from policies, information that is shared. So really, I wouldn't say that it is sort of the information that is kept and not. And a lot of work that has been done are really collaboration between university, whether private university or public university, with the Ministry of Health facilities. So in terms of the what do you call it, the environment of research, we currently there's an institution in National Institute of Health in Setia Alam, and in that institution it holds 6 institute covering the IMR for the diagnostic, you have the behavioral science, and the CRC that I'm heading is actually under the Institute of Clinical Research. And under that Institute of Clinical Research, there are actually 36 networks of CRC throughout, distributed throughout Malaysia. For example, in Perak itself, we have 1 CRC in Taiping, 1 CRC in Hospital Raja Permisi Bainon Ipoh, and 1 in Hospital Sri Manjung. So that gives you a very wide coverage of possible collaboration in terms of research. And some of these clinical research centers have their key opinion leader in specific field, and that gives opportunity for anyone who is interested for collaboration to work with. For example, recently Sarawak GH has published a paper in the European Society of Cardiology, ECS, with the work using the smartphone detection of intermittent atrial fibrillation, and it's shown that in people above the age of 55, using the smartphone detection is improved the detection of this idiopathic stroke, comparing with the more traditional way of using Holter. And we know that intermittent AF, and you use a Holter, is something like you're playing on luck. You expect that the intermittent AF to occur on the day that you decide the appointment given to patient, and so these are a lot of opportunities. And certain CRC, the strength are neurologists, and areas that we can look in is, for example, diseases like Parkinson's disease. And we know that even though Madopa is still the most effective treatment for Parkinson's disease, often the timing may not be the best. As disease progresses, people go on to these motoric complications. So the on and off time, patients are prescribed 3 times a day, for example, and they may not, the best time for that particular patient may be actually 8 a.m. and the next dose could be actually 11 a.m. depending on the meal time. And this is an example, because Madopa in advanced stages are very dependent on the meal time as well, because food interferes with Madopa absorption. So personalized care is endless in terms of opportunity. But I think what Prof Maude has correctly brought out is 2 things. One is the low-lying fruits, and the other one is really we probably need a roadmap for the country, and that will be more helpful in the long term. And in terms of fund, for example, we do have the NIH grants. You have also, because it's a personalized healthcare, grant can also be obtained from the Ministry of Science and Technology and Innovation. But in the long run, of course, a specific fund dedicated for this digital health, personalized health, and precision health is probably what we should aim for. Okay. So this is just a summary, and if any specific question, I'll be more than happy to answer it.
Thank you, Dr. Chia. I like it that you mentioned about low-hanging fruits and some that require much more deliberate move or momentum to achieve. And Prof Maude clearly highlighted in her own presentation several possibilities for Malaysia to work on. And I want to expand a little bit further on the area of research, and I will put this forward to Professor Dr. Teo. You're a researcher in this field, and I want to get your take on 2 areas really. How does personalized healthcare fit into the work that you're doing right now, developing an oral cancer vaccine? And also, how do we use research on personalized healthcare to make the kind of changes or reforms that we need in terms of the services themselves in terms of the healthcare system itself. Go ahead, Prof. Teo.
Thank you, Azrul, for inviting me to be part of this panel. I think it's really important to note two things. The first is that precision medicine and personalized healthcare requires research to take place in different populations in terms of really knowing what is going on in the different populations in terms of the diseases in those populations. So for example, as we've talked about nasopharyngeal cancer, and this is a disease that is predominantly in the Asian population, just like oral cancer is predominantly in the Asian population. So I think for precision medicine or personalized healthcare to take place, first and foremost is we need to have more data in the Asian population. And I think there needs to be a funding stream to enable that type of research to take place. And I'm very much encouraged that at the national level, to the National Science Council, there's now been a lot more effort to try and put a strategy in place for funding in two areas, personalized medicine and also in digital health. And I think that bodes well for what will happen over the next 5 to 10 years. But I think the second area is what you've also highlighted, that precision medicine and personalized healthcare doesn't take place unless you can invest also in the policy and the implementation side. And what I mean by that is, in order for us to be able to think about how can we take the genetic testing methods that we now know about, the panel testing, the polygenic risk scores, and so on, that we know can help people understand whether they have an 87% chance of developing cancer or a 2% chance of developing cancer. How can we ensure that this can then be rolled out effectively? Because we then need to make sure that it's tied in with screening, it's tied in with prevention, it's tied in with early detection, and it's also tied in with the psychosocial aspects and genetic discrimination and so on and so forth. So there needs to be a policy shift. And unfortunately, it's not so clear how that will actually happen. It's not clear what will we prioritize. Will we prioritize cancer? Will we prioritize which cancer? Will we prioritize heart disease, stroke? Well, what will we exactly prioritize? Because unfortunately, when you're trying to stretch our dollar or ringgit to cover many, many things, it's impossible to do all of them. If you try and do all of them, you'll do none of them as a consequence. And we need some mechanism by which we can prioritize at the national level, just like what Prof Dr. said. There needs to be a policy shift at the leadership level to enable us to prioritize. But I want to kind of really also comment on this, right? Which is that we must not forget that whilst that if we don't do anything, personalized medicine will happen in this country anyway, but it will only influence the lives of those who are wealthy and can afford it in the private hospitals and so on and so forth. It's not going to influence the outcome of the bulk of the people in this country. And so what we need to do as public health and as well-intentioned individuals is to ensure that we find opportunities by which we can use the technologies to be able to leapfrog from where we are today to where we want to be. And I'm going to give you some examples of that. So for example, currently we think that in order for us to do early detection of cancers, we need to follow what others have done as a tried and tested method. We need to put in place mammography screening for everybody. We need to put in place colorectal screening for everybody. But that might not be the solution for us. Maybe instead of putting in place that kind of screening strategy and then inheriting, all of the overdiagnosis of breast cancer, the overdiagnosis of prostate cancer, maybe this is an opportunity for us to think about what do we need to do as a demonstration project that enables us to leapfrog so that we learn from the mistakes that other countries have inherited and they cannot undo, but use technology to enable us to leapfrog. And leapfrogging requires leadership at the national level, which is why Prof Rahman talks about a policy shift and ensuring that policy shift and leadership is what we really need if we want precision medicine to really take an impact. So you take a country like Singapore, for example, they're number one on this leadership board. I know that where Prof Maude made a point not to compare, but the reason why I want to highlight Singapore is when they looked at precision medicine, even for a country like that, they felt that they don't have enough money. So I know the two chairs who are leading the precision medicine effort in Singapore, and Prof Patrick Tan said that even for Singapore, they're not going to have enough money. So they need to prioritize. and they need to think outside the box. So what Singapore did was they basically started and said, okay, we're going to consider this possibility that we're going to just do the whole genome test for every Singaporean, because we only have 5 million people. We're going to do whole genome sequencing for 5 million people and then plan out services in that way. And that really is turning things around on their head to be able to kind of say, how can we save money for the country? How can we really improve healthcare? How can we lead from the top? I think the opportunity for Malaysia is to really think about what is the solution that will be right for us? What can we think about that will be better for us from a precision medicine initiative?
Okay.
Because it's not really going to be just to find what works in high-income countries, but to think about what is valuable and practical for our country and how can we leapfrog for our own country.
Thanks, Prof Teo. Those are really strong questions that need answering. Honestly, there's quite a few challenges there as well. And I want to put this question to Prof Maude, since she presented at the very beginning. And I know, Prof Maude, you stressed not to compare with other countries, but you know, we're Malaysians, we like to compare against other countries. But I mean, you did mention that, you know, in terms of what other countries are doing. So I need to ask you this question, taking into consideration what Prof Teo has already also mentioned, which is concerning our priorities concerning this issue. When it comes to personalized healthcare, what are the low-hanging fruits that was mentioned just now by Dr. Chia? What can we do today? And I think, first of all, we need to answer this: where are we in terms of the state of preparedness for adoption of this compared to other countries? Okay. So go ahead, and we'll go to the second question, which is, what can we do today? What can we invest today to prioritize today? That challenge that Prof Teo mentioned in what she just said just now.
Okay, now I need to qualify in terms of not comparing, because when one has an index, there's the automatic thing people do, will start comparing. Yes. And then you get so depressed and you say, oh, Malaysia is number 8, that's really bad, let's forget about doing anything, you know. Singapore is number 1. Singapore will always be a nation state. And we know that Singapore is leading the way in many things, not only in personal healthcare in the region. And it's quite true what Su Huang has said, that yes, there will never be enough money to meet everybody's needs. And we talk about distributed justice and healthcare. So the health needs will always exceed resources that any country is able to provide, sort of like, you know, bioethics, medical ethics 101. However, I do think there is a point here where when we looked at the index, and we are ranked 7th for personalized health strategy. Now, this is a wake-up call for us, okay? Not in terms of getting too upset about it, but it's a wake-up call to say, hey, a lot of other countries among the 11 in ASEAN and Asia Pacific are doing so much better. What is the issue here? And I was quite glad that the index was able to uncover this, because we've known about this for the longest time, that there have been various Rancangan Malaysia, Pertama, Kedua, Ketiga, and all that. There have been various changes in government, and we have had several strategies where the strategy has been so wide, it has really not been focused enough to actually track measurables. I don't think, you know, in my experience anyway, and I stand corrected, there have been any really serious conversations that engage more stakeholders apart from just people within a ministry, or apart from a few maybe local national experts, to look at the issue from a very holistic global angle, right? So yes, we are number 7 for health strategy. And we are saying in the index, and I don't have all the answers for you today, and this is why we're having these conversations and starting these engagements, to actually look at some areas where we need to advance priority areas within the national strategy that have measurables, right? Now, we've got all sorts of things that have happened in the past, I don't know, 25 years or so, which have never really been followed through per se in terms of the measurables. So once we actually, I mean, we need to get our act together, let's put it this way. We do need to get our act together. There are many areas that will be interesting would be, in terms of a cost-benefit analysis, that will have to be thought through. And within the policy, there must be areas where, the government or the nation says, okay, this is an area that we're going to put money on, that we're going to have concrete measurables. Now, the index, the vital signs are quite useful. They can help you track the measurables. So without measurables, it's just another policy and yet another policy.
But just to pick up on your point there, Prof Maude, Prof Rahman just now spoke heavily on the need for us to have a DASA, basically policy, right? That we got to have on personalized healthcare. And you indicated yourself, I think, and also Prof Rahman, we don't have one at the moment on personalized healthcare, right? So Prof Rahman, I want to challenge you. I mean, what is the benefit of having a policy at this stage? Can't not just private sector just start doing it right now? Why should we need a lead from the government to have a policy in order for us to start doing the work? Go ahead, Prof.
Well, I think I need to add that the ball has started rolling. Yeah? We initiated the sort of development of a position paper right from 2019 at the Academy of Science, and in parallel, the Ministry of Health as well has set up a task force for the precision medicine initiative as well. It was nicely sort of done in parallel. So when we met together, the academic science representatives and the Deputy Director General of Health, Dr. Shamshah, we saw that our position papers were quite similar in terms of the direction and the agenda. So this paper, this joint paper has been presented at the National Science Council meeting in February, chaired by our Prime Minister. And we are in the midst of preparing a cabinet paper for this. And we are looking into the key points, and as what Prof Maude, Prof Teo has said, we need to prioritize. And this paper itself is not only on precision medicine, but also on digital health, which is, of course, another important component. If you look at the need for electronic medical record or electronic health record, and also clinical trials hub, of which we know we are well established in terms of having a good number of clinical trial centers at both the MOH key hospitals as well as university hospitals. So these three components are sort of embedded in the position paper, and the National Science Council has approved this. So I think this is a big step into entering or moving into having a national policy for precision medicine. And I think to answer your question, this is the first move, and a big move indeed, because this will trigger a lot of discussions at many levels of stakeholders, including clinicians, the laboratory researchers, insurance companies, regulators, and so on, because all this must come together to fill up the gaps if we were to embark on a national policy, hence the big initiatives in precision medicine. I hope that answers your question, Azrul.
I think it does. And it's very encouraging to already hear that it's harmonized, it's salary, right? You're actually thinking along the same lines and coming together with a joint paper that's going to be presented to the cabinet on this issue. I think that's very, very encouraging. And I'm sure stakeholders out there in the private sector are very happy to hear that. So, unfortunately, Dr. Azrif had to leave us a moment ago because he has clinic and is unable to continue on with us. I just wanted to remind everyone out there again to please send your questions through the Q&A panel at the bottom of your screen. If you have any questions for our panelists, I've just got one through WhatsApp, interestingly enough. I'm going to address this question to Prof Teo and Dr. Chia. And, both of you, to some extent, work in the areas of research which requires collaboration, which requires partnership between both the public and the private sector. And you each have your own success stories on how this has already worked. Now, when we talk about personalized healthcare, it sounds like this is going to have to be the core of this initiative that we need to incorporate. So how can, when we're looking at this issue, can you bring from your own respective examples to the table to ensure that we have a successful collaboration? Because public-private partnerships in Malaysia have had a rocky history, but both of you have had good stories to tell and success. So what lessons learned can we take moving forward when it comes to personalized healthcare? If I could ask Prof Teo first.
Thank you, Azrul. So I'm going to kind of share a couple of stories maybe with the audience on what we have actually done here. So we know, I mean, the BRCA1 and BRCA2 genes were discovered more than 20 years ago, but even today there remains many disparities in terms of the access to such testing. And whereas testing for the past was really to try and know what is my risk of cancer, what's my family member's risk of cancer, there are now new treatments that have been developed so that a patient with breast cancer or with ovarian cancer or even with prostate and pancreatic cancer soon, who have these genetic alterations, actually can access a new therapy that works more effectively than the standard chemotherapy options. So the reason why we want to roll out testing is really not just for management of risk for themselves and family members, but also about therapeutic options. But the challenge was the following. Number one, who would pay for the test? Number two, would clinicians know how to interpret the test and offer services? Number three, how would you roll out services when you don't have enough manpower to be able to do so? And then number four, who would do the genetic test? What's the quality of the genetic test? And so on and so forth, right? So there's a lot of challenges, many of which are good case examples for the challenges that we have in terms of rolling out precision medicine. So what we did is in this rollout program or implementation program, we started off by a partnership between Cancer Research Malaysia and one of the pharmaceutical companies through an educational grant to be able to set up a national study where we would do three things. One, make sure that the genetic test was done in a robust manner. Number two, make sure that we could train clinicians to incorporate this into their services. And number three, work out whether patients would want to know their results if such things were available to them. So elements which are very critical if we're going to be able to roll out precision medicine in this country. And to cut a very long story short, it took us a long time to set up the study. It was complicated to be able to set it up. But to be able to set it up, we'd then be able to roll out on 23 sites. We had a program or a hospital in every state in this country that was participating in that study. We rolled out initially for ovarian cancer because it was easier cancer to do because there was smaller number of patients and specialists who were very keen to work with us. And to cut a long story short, we were able to show that mainstreaming was feasible. Number two, we improved access to genetic testing from 2% to 65%. And number three, there was no impact or very little impact on the psychosocial outcome for patients. And we showed that the patients were very receptive and family members were also very receptive. So this is an important demonstration project because it shows for the first time in a middle income or low middle income setting that precision medicine at a national level can take place and can be acceptable to individuals. And our next step now is to really do the budget impact analysis, which is ongoing. And hopefully by the end of this year, we'll produce a white paper that shows that this is a pilot implementation project on a roadmap of precision medicine for at least for the space of preventative and screening healthcare and so on. The next phase is to really work out how do we take this forward for treatment. So in that space, what we did was we started with research grants that would help us build a better understanding of genomics in the Asian setting, and we did this for breast cancer. We then be able to do private partnerships in order to be able to fund a lot more studies in research. And we then went on to identify biomarkers that we're now taking into clinical trials. And those clinical trials are being funded either in full or in part by the pharmaceutical industry. So again, public-private partnership through partnership with the pharma industry for the provision of drugs or through international global research grants, partnership with the ministries through research grants, partnership with the universities through training of students, partnership with public and private hospitals through the establishment of investigator-initiated trials and so on. So I think what I'm trying to say is that all of these actually possible to set up in Malaysia. So if we continue to take this journey, making these demonstration projects possible, informing on the national strategy that Prof Rahman Jamal and others are taking the lead on in the policy shift, I think we're going to be able to accelerate the progress that we're making in precision healthcare and in personalized healthcare. So I'm optimistic.
So the demonstration projects that you mentioned, I mean, could you give us a little bit of a flavor of what you mean by that? What kind of projects that we're looking at?
Right. So the first demonstration project was on ovarian cancer and rolling out BRCA1 and BRCA2 testing for all ovarian cancer patients. And that's the one that we showed that you could improve access from 2% to 65%. Once we complete the budget impact analysis, what we plan to do is put that up for the Ministry of Health to consider incorporating it into their services so that we can then roll out, rather than just as part of the research study and just a flicker, roll it out as a national program so that it gets incorporated into the services in the future.
Yeah.
Right? And I think that's an important, that's what I mean, that you need to go from the research to know what genes are involved, to know how it would change services, to actually doing these demonstration projects and then doing the budget impact, and then after that, hopefully incorporating it into services, right? And now what we're doing is doing that not just for breast cancer. By the end of this year, we hope to be able to launch the study for breast cancer, which of course is a bigger challenge because every year you have 1,000 new ovarian cancer cases. Every year you have close to 6,500, if not 7,000 breast cancer patients. So the scale of the problem is a little bit different, but we already have all of the study design in place. We hope to be able to roll out the demonstration project for breast cancer with launch it by this year, and hopefully be able to roll this out, as a national problem within the next few years.
Thank you, Prof. Teo. Dr. Chia, from your perspective, I mean, seeing you in the public health system and working in collaboration with different stakeholders on research, from your perspective.
I'll just keep the answer short, but I'll just illustrate two examples of interagency and inter-institutional collaboration. One of it is, for example, the collaboration between the CRC network of the Ministry of Health with the University Malaysia on the genetics of Parkinson's disease, the young onset Parkinson's disease. In cases where you have rare diseases, obviously a network, it has a strength there because you need to have engage more people that would collect information from Malaysia as a whole, as a country, and not just collecting blood samples and all that. You also need specific expertise there. For example, when you do a genetic for Parkinson's disease, you need someone who are able to do clinical assessment for Parkinson's disease. Several tests you have to do it. So this is where the network strength is there, where the need is there, and then the matching of the experts and the center that could help, because some of the centers, for example, a neurologist may be a single person in the hospital, and without assistance from, say, a clinical research area, may not be able to handle that kind of extra additional work to collect genetics material, for example. So this is just one project that's going on. Okay. Yeah. Second one, I just want to also highlight interagency collaboration. One example for the country, for example, this is basically on digital healthcare, where there is an invention of an AI stethoscope by our local industry, and these are not necessarily medical-based industry, and they develop this through audio ability, and with this kind of stethoscope, it is wireless. You can transmit the sound through a telephone, as long as you have a telephone line, and that could really change the way we diagnose cardiac disease, pediatric cardiac disease in a very rural area, accounting for equity of care and all that. And that is where, again, the National Institute of Health has worked together with the other industry to get it through the clinical ethics part of it, the medical device authority approval for it, and finally getting it to clinically prove that it's actually it's a validated test of clinical capabilities, and that is another example of interagency collaboration, not necessarily just between a health organization with another health organization. And the last example I want to give is that currently already went through the ethics approval is the basically on wearables, and we know that in COVID-19 now one of the challenges is to find a lot of centers that could cater for the asymptomatic but laboratory confirmed COVID-19 infection. And of course, getting a home quarantine is one way, but sometimes we also fear the breach of SOPs, and as a person may leave their place. So the wearables now adopts biosensors, adopts geographical information that would allow, if proven effective, will allow a person confirmed positive, not only safely medically to be quarantined at home, but also safe in terms of ensuring that the quarantine is adhered to by a real life geographical location of that person. So these are ongoing projects, and yeah.
Yeah, so Dr. Chia, you've mentioned several examples of digital health, and definitely some local innovations that have arisen over the past couple of years, but also mentioning several points that were highlighted by the other speakers just now about how COVID-19 has actually resulted in an acceleration of our work in digital health. I mean, let's face it, Malaysia hasn't been that great in digital health ever since, the very beginning when we're talking about telemedicine, right? Today, in a very short period of time, we've seen a tremendous acceleration in this area, especially when it comes to connecting patients with doctors, trying to get distance diagnosis, trying to be able to connect for follow-ups, consultations, etc. So, if we wanted, is it correct to say that if we wanted to invest today, digital health infrastructure would be one area that we can expect a good return of investment?
Yes, totally agree with that. Yeah, I think it's a great area, a great potential. I think it's also shown in the index. And one of the strengths is the research capability, and one of the big area, a very small percentage of wearable usage in this country. So there's a lot of opportunity there. But the other thing about the obstacle here is also whether it's chicken or egg, because there's lower usage of wearable, there are limited companies that would want to basically sell their product here. And when you have a limitation of that, there is also ethical issues of conducting that clinical trial. If we are not talking about using it as a health lifestyle wearables, but a medical graded wearables, and you even do a clinical trial and the company has no intention to sell it, there are some ethical challenges that we have to prove to, that why are we conducting the study in this country. So these are the areas that, chicken and egg, we have to solve the wearables utility, the how people acceptance to use it, then the
we can use that data that comes out from the wearable data.
And most wearables are also not synced. So one company's information may not be linked to the other, and you have this disjointed information as well. Not just disjointed within our health system, but also within this industry. So these are, again, a very important time, a policy platform discussion together, all the key policies person, and have a prioritization of where we should head in the next 5 to 10 years from now.
Thank you, Dr. Chia. I think Prof Maude, maybe you're the best person to answer this. We've got some excited GPs attending, they're listening to personalized healthcare, but it seems almost either academic or a much more system scale type of initiative, or specialized researchers like Prof Teo and Dr. Chia. How can GPs get involved when it comes to personalized healthcare? Prof Maude.
Thank you very much, Azrul, and I hear all my colleagues here. It's wonderful responses. I did respond to the Q&A, and I think this is where I like to reiterate that we will try to roll out programs to actually create the ecosystem to enable personalized medicine. And one of that is very importantly to educate and also make the GP community, our health providers are all aware of what it is. So for some people, of course, it's probably a lot to take in. Some people might know a little bit about it. So I think at the school, we will probably organize some event later on that seeks more to give some educational perspectives to GPs, and whoever is interested, please email myself and get in touch, and we will take note of who's interested for our rollout program later on.
Thank you, Prof. Maude. And, you know, we're coming to the end of the session this morning, which has been quite, I think, a robust to and fro on this issue, and different perspectives are being shared. I feel like we need a part 2 of this webinar, honestly. Maybe we're going to have to organize another one after this. To sort of conclude the discussion this morning, perhaps I could have input from each of you as to where you, as in your own individual capacity, feel that the government or perhaps different stakeholders should be able to invest in for the next half a decade, you know, in this area of personalized healthcare. If you had some funds or resources that you could put your money down into, where would you put this money? I would go first with Prof. Rahman. What would you prioritize?
Well, I think there are a few things that needs to happen together, not in sequence. There are other initiatives that could be started in sequence as well. But I believe putting up big initiatives in terms of setting up a sort of established genomic medicine centers to do some key or targeting certain strategic diseases is important. As important as well as developing policies, guidelines, and regulations, because as we know, there are gaps in terms of our current acts, in terms of controlling genetic information, as well from being used for discrimination and so on. Issues like insurance coverage, possible deprivation of employment and education based on your genetic makeup, these are still non-existent in terms of our guidelines. And I think probably another important initiative that we should start is, as mentioned by others as well, the public engagement, especially to get their trust, because we are talking about genetic information, and this is not about renal profile, you know, blood sugars and so on. This is about your genome. And I think getting the public to trust our healthcare sort of providers, that we are handling their genetic information in such a way that this do not get into the wrong hands and will just be used to benefit them and also maximize the effectiveness of treatment for them and the population. I think I can just sum up there, Azrul. Thanks.
Thank you, Prof. Rahman. Dr. Chia?
I think again, it has to be done in several stages. Yep, the one that I think we can do now is the collaborations, continue to produce good results, and then that results must be visible to the policy makers, not just published in a journal and just between the specific groups of people who knows about it. Second is then having more of this kind of engagement with the key important people to also make the policy makers understand the importance of it, and that will make acceptance much easier when we basically meet them. And really we need a platform where we can come together, not just from one industry, but many industry that is related to personalized healthcare, precision medicine. And again, that's a long-term plan that we have to have a national a roadmap on where is the prioritization, how do we measure it, what are the indicators of success that we are looking at, and then focus on the resource, and then also include training, starting from medical school itself, and then developing that key specialized person. For example, oncologists, if you're talking about cancer, we still have very limited oncologists in this country, and towards that. So that's my summary.
Thank you, Dr. Chia, for emphasizing on the need for evidence-based policy making, and bringing the findings of research to guide policy making. I think we don't do necessarily enough of that. And for also highlighting the role of capacity building, training people in this area. I mean, we can't assume that people know, and certainly it helps to obtain the kind of support that we need in order to expand on this area. Prof Teo.
I think my comment would be to say that we first need to acknowledge that we can't do one thing and expect all of it to change. The reality is that it's going to get, the policy is important, the infrastructure for the laboratories are important, the infrastructure for the EMR and the data is important, the capacity building is important, and so on. If we go about and just choose one thing to do as a priority, the reality is that something else is going to be the weakest link. So I agree with Dr. Chia that a national roadmap is really important because it enables us to take a global view of what is important and make sure that with each of the things that are important, we know what is the immediate next step that is a priority for us to continue to move each one of those, because it's a lot of moving parts. And if we only push one of those moving parts, we're never actually going to get to a goal. We need to kind of push every one of these moving parts in order to be able to make sure that we progress each one of those. I think that while we're waiting for a national roadmap, it is really important to continue to fund and support the discovery projects, the demonstration projects, the implementation sites, and to continue to advocate our policymakers that we need to have those demonstration projects. Otherwise, policy will be a very nice file or book that sits on the shelf. Until there are implementation studies that are then tied into changes in the system, the reality is we're not really going to be able to roll out the appropriate system, I feel.
Thank you, Prof. Teo. So many points to comment on that. It seems like we want to push all the buttons or wait until the conditions are right in order to move forward, but we just can't, and you've highlighted very importantly the need for us to look at these issues within context. Prof. Maude, I give you the last word on the topic today. Go ahead, Prof. Maude.
Thank you very much, Azrul, and everybody here who's contributed so substantially to the discussion. Most of my recommendations have been articulated by most of the colleagues here already, and I don't really have very much to add, except that I think we should be we should take account into how much we're spending in terms of health expenditure for the country and see whether or not we can actually try and maximize the utilization of that expenditure. And one way is to sort of look at different ways of doing it rather than a one-size-fits-all that was mentioned earlier. So go to the budget and see. I mean, the money talks. Let's look at how we can make economies by making better decisions and utilizing personalized healthcare. And the second thing I think I would want to say, which has been the experience of many countries as well, not just Malaysia, but the countries in the Asia-Pacific Index, was that we must actually look at greater interoperability of records, of systems, and having better systems of capturing health-related data. It's not going to work very well if it's just one hospital with its own system, which doesn't talk to another hospital with another health system, and so on. So I think it is going forward, we need to pay attention to data interoperability, right? So we are transitioning towards personalized healthcare, and there is enormous potential, and very happy to be part of this conversation, So yeah, thank you very much, Azrul, and I thank everybody here. Yeah.
Thank you very much, Prof. Maude. And I just wanted to also end on this comment that just came in at the very last minute, as all Malaysians do. We all do things last minute, right? But this excellent comment that came in, which is that we need to have buy-ins from all stakeholders, including disadvantaged groups, clinicians who are working at the coalface of genomic medicine, bioinformaticians and public health experts, and the industry, besides the government and patient and consumer groups. So definitely there's already a call for a part 2 of this webinar. So we'll see what we can do. And we're happy to collaborate again with the Jeffrey Chia School of Medicine and Health Sciences. Thank you again to all our distinguished panelists, and to all of you who have taken the time to be here and participate in this webinar. It has been a fascinating discussion and forum on this topic. I hope that you have learned a lot on personalized healthcare. I certainly can say that I have, and I once again thank you all for being here. I'm Azram Al-Khalid from the Galen Center for Health and Social Policy, signing off and wishing you all a great weekend. Goodbye.